Okay, let's just state the obvious. Breathing is the most vital function we have, right? But the moment we push those induction drugs, we start messing with it, systematically. So in this explainer, we're going to break down that critical relationship between anesthesia and the lungs. This is a really high-yield review, perfect for anyone in the OT or the ICU.
So why do we focus on this so much? I mean, why is it our obsession? It all comes down to this number right here, 70 to 80%. Just think about that. That's the percentage of major perioperative complications and even deaths that are linked back to the lungs. It's staggering. This isn't just some number you memorize for an exam. It's a reminder every single day that our patient safety really depends on us getting this part right.
All right, so how are we going to tackle this? We've broken it down into 5 parts. First, we'll talk about the big picture, the respiratory challenge of anesthesia. Then, we'll get a solid baseline of how the lung is supposed to work. After that, we'll dive into how anesthesia just completely disrupts that. We'll look at the consequences, atelectasis and hypoxemia. And finally, the most important part, we'll cover the clinical strategies we use to manage it all.
Okay, let's jump right into Section 1, the challenge. The second we induce anesthesia, we are taking complete control of our patient's breathing. It's on us now. Every single thing we do, the drugs we pick, how we position them, every little adjustment, it all has a direct impact on their ability to exchange gas.
In this quote right here, it just says it all. A deep understanding of respiratory physiology is essential for patient safety. It's not just about passing an exam, right? It's about knowing this stuff so well that you can apply it in a split second, right there at the bedside when it really counts. This is, without a doubt, the foundation of everything we do.
Okay, so before we can really get into what goes wrong under anesthesia, we have to know what right looks like. So let's set our baseline. What does a normal, spontaneously breathing lung actually do? Because honestly, everything else builds on this. Now, when you look at a diagram like this, you see all these different lung volumes, tidal volume, vital capacity. You know the drill. But here's the thing. There is one parameter that is absolutely critical for us, one that anesthesia messes with more than any other, and that is the functional residual capacity, or FRC. So let's zoom in on that one.
So what is FRC? Well, the textbook definition is the volume of air left after a normal passive exhale. But I want you to think of it differently. It is not just leftover air. It is the patient's personal built-in oxygen tank. This is the oxygen supply that keeps them going between breaths. It's our safety buffer. When a patient is apneic, this FRC is the only thing keeping their SATs up. For all practical purposes, FRC is their oxygen reservoir. Super important concept.
All right, so we've got our baseline. We know what a normal lung is doing. Now, let's throw anesthesia into the mix. And you're about to see how it just systematically takes apart that normal physiology and creates a whole new ball game.
Okay, so check this out. On the left, you've got an awake patient. They have normal muscle tone, their diaphragm is working, their FRC is good. Now, look at the right. We induce anesthesia, and bam, the muscle tone is gone. The abdomen pushes the diaphragm up into the chest wall kind of sags inwards, and the result? It's immediate. That FRC, our precious oxygen tank, shrinks by 15 to 20%, just like that. Gone.
And it's not just a mechanical problem, not by a long shot. Anesthesia also shuts down the body's built-in alarm systems. Think about it. Normally, you have these little chemoreceptors that are constantly monitoring your blood. If oxygen gets low or CO2 gets high, they basically scream at the brain, breathe faster. Well, anesthetic agents just blunt that response. They put those alarms on silent. Suddenly, the patient's own drive to breathe is gone, and they are 100% dependent on us.
So what does all this lead to? It leads to this huge problem we call VQ mismatch. V stands for ventilation, that's the air. Q stands for perfusion, that's the blood flow. In a healthy lung, they are perfectly matched up. But anesthesia, it just shatters that balance. You start getting these areas where blood is flowing just fine, but the alveoli it's flowing past are collapsed and have no air in them. That's what we call a shunt. It's literally blood taking a detour through the lungs without picking up any oxygen. It goes right back to the heart completely deoxygenated.
Okay, so let's recap the damage so far. We've got a smaller oxygen tank, our FRC is down, we've got silenced alarms, so no drive to breathe, and we've got a big VQ mismatch causing shunt. Now, these aren't just, textbook concepts. They lead directly to two very real, very dangerous problems for our patient.
And this right here
This is the domino effect. This is the path to hypoxemia. It all starts with induction. First, the FRC drops. That causes the tiny little airways down at the bottom of the lungs to just close off. With no air getting in, the alveoli collapse on themselves. We call that atelectasis. But blood is still flowing past those collapsed alveoli, creating that massive shunt we were just talking about. And the final domino to fall? Hypoxemia. The patient's oxygen levels start to drop.
So knowing how this whole disaster happens is one thing, but preventing it, managing it, that is the art and science of what we do. So let's get into the good stuff. Let's talk about the practical, high-yield things we can actually do to keep our patients safe.
This is what I like to call the anesthesiologist's toolkit for the lungs. We basically have 4 big guns in our arsenal. We've got pre-oxygenation, PEEP, that's positive end expiratory pressure, smart patient positioning, and recruitment maneuvers. These are our cornerstones. Let's start with the very first one, and maybe the most important, pre-oxygenation. Now, pre-oxygenation is so much more than just slapping a mask on and giving some oxygen. It's actually genius. For those 3 to 5 minutes when the patient is breathing 100% O2, what are we really doing? We're washing out all the nitrogen. See, the air they were breathing is about 79% nitrogen. We're actively swapping that nitrogen out for pure oxygen. By doing that, we turn that FRC, even the shrunken one, into this super concentrated oxygen reservoir. This is what buys us precious, critical minutes of safety if we run into a tough airway.
And listen, this doesn't all stop when the case is over. This is hugely important in the ICU too. The whole game in the ICU is about reversing these effects and getting the patient off the ventilator. This table, this is pure gold, both for your exams and for clinical practice. These are the numbers we look at, the objective data that tell us if a patient's lungs are ready to fly solo again. You've got to know these criteria, from the RSBI to the NIF, to safely get someone off the vent.
So, at the end of the day, what's the big takeaway here? It's this. From the moment you induce to the moment they're waking up, every single breath is on you. It is an actively managed process. The lung is not on autopilot. We are in the driver's seat. So the final question I want to leave you with is a personal one. How are you going to take these principles and make the very next breath you manage even safer for your patient?